The course of mantle cell lymphoma is many times convoluted, as this is an aggressive disease. Median overall survival incorporating intensive therapy is 8 to 10 years. Shorter survival times are seen with less intensive therapy. For relapse refractory setting, you have 3 BTK inhibitors currently FDA approved for mantle cell lymphoma, including ibrutinib, acalabrutinib, and zanubrutinib. Other options include bortezomib, the immunomodulator lenalidomide, and the BCL2 inhibitor venetoclax. Now, patients that are relapsed or refractory after a BTK inhibitor have a very ominous prognosis with survival measured in months. Hence, this led to conducting several trials trying to salvage this population of patients. The inclusion criteria for SUMA-2 was for patients with relapsed or refractory mantle cell lymphoma after up to 5 previous therapies, and all patients needed to have received a BTK inhibitor previously. Needless to say, this subgroup of patients face an unmet need in lymphoma, and the SUMA-2 trial did allow patients with high-risk features to enroll, including patients with high Ki67, TP53 abnormalities, high MIPI score, and blastoid or pleomorphic histology. These patients are the sickest of the sick and historically have done very poorly with standard chemotherapy. We know that chimeric antigen receptor or CAR T-cell therapies as Axi, Captogene, Silolucel, or Axi-cell for short have displayed efficacy in patients with relapse or refractory aggressive B-cell lymphomas like diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, and transformed follicular lymphoma. KTE-X19 is also an anti-CD19 CAR T-cell, which means that you are re-educating those T-cells to target cells that express CD19, which is present across the board in multiple B-cell malignancies, including mantle cell lymphoma. The KTE-X19 data as part of the SUMA-2 trial was presented by Dr. Michael Wong recently at medical conferences. Furthermore, KTE-X19 is particular in the way that it's produced in a manufacturing process that removes circulating CD19 expressing malignant cells, which could potentially be present in patients with leukemia or lymphomas. The removal of these CD19 malignant cells decreases the chances of exhaustion of anti-CD19 CAR T cells during the manufacturing process, making it more seamless. SUMA-2 was a phase 2 trial that analyzed data for 74 patients enrolled. The results showed 93% of patients had an objective response and 67% of patients had a complete response. KTE-X19 was manufactured for 71 patients and administered to 68 patients. Hence, when you look at the intention to treat analysis, objective response was 85% and complete response was 59%, which are still impressive results. At 12 months, the estimated progression-free survival and overall survival were 61% and 83% respectively. Very similar to the CAR T cells previously approved for aggressive B-cell lymphomas, serious and life-threatening toxic effects that were consistent with those reported with those other constructs. The main toxicities for CAR T cells in general are cytokine release syndrome and neurologic events. Grade 3 or higher cytokine release syndrome and neurologic events occurred in 15% and 31% of patients respectively when it comes to KTE-X19.